Let's talk about GERD, gastroesophageal reflux disease. So before we talk about the disease process, we got to talk about anatomy. So here's your stomach model. This is where the esophagus would be. The esophagus is a pipe or a pump that gets food from your throat into your stomach. Think of it as a conduit. Your stomach here is a reservoir for food. This is your small intestine. Patients get reflux disease because there's an escape of acid into the chest where the esophagus is. Your esophagus is not supposed to see much acid. So why does that happen? One of two reasons. Most patients get reflux disease because they have what's called a hiatal hernia. There's a hole in your diaphragm that if it gets too wide, can cause a herniation of your stomach into the chest where you have negative pressure and where the acid gets sucked up. The second reason, about 10 or 20% of patients, as opposed to 80 to 90% of patients who have a hiatal hernia, about 10 or 20% of patients just have a non-existent or very loose sphincter, or they get what's called transient lower esophageal sphincter relaxations, which means that sphincter is loose much more than it should be. So the typical symptoms of reflux are heartburn and regurgitation. Heartburn is a burning sensation that you get behind your chest. Regurgitation is the feeling of liquid or food coming up into your mouth. Atypical symptoms are throat symptoms. Why do we differentiate heartburn and regurgitation from atypical symptoms such as cough and hoarseness, feeling of food getting stuck in your throat? Because typical symptoms are more likely to improve with surgery. So who gets surgery? Well, a lot of patients are happy just taking antacid medications. The issue with those antacid medications, especially the PPIs, Nexium, Prilosec, Prevacid, is that those medications can have side effects long-term. So things like osteoporosis, kidney issues, GI infections, lung infections, dementia, if you're on these medications for a long period of time. So if you don't want to be on medications long-term, or you're not getting enough control of your symptoms with the medications, or perhaps your regurgitation, which you can't fix with medications, is problematic, well, that's where surgery comes in. Any operation that you do, you have to address the hiatus, which means even if you don't have a very big or obvious hiatal hernia, you have to put stitches in the diaphragm to make it narrow. So what does all this entail? So if this is your esophagus, this is your stomach, this is your diaphragm. If that hiatus is too loose, the stomach can go up into the chest. We bring the stomach back down. We tighten things up. We can't make it too snug, otherwise you can't swallow. And if we just stop there and only do the hiatal hernia repair, 50% of patients will recur. Their stomach will find a way to go back up into the chest. So then you have to add one of the few different types of operations. The most common operation done around the world is the fundoplication, where we wrap the stomach around the esophagus like a hot dog in a bun. There's different types of fundoplications. The full wrap used to be very common. Nowadays, in all parts of the world, most people are doing the partial wrap. Why do we do a partial wrap? Well, it has just as good of acid control as the full wrap with less side effects, less bloating, and less trouble swallowing. So why would anybody do a full wrap? Well, guess what? In Europe, no one's doing the full wrap. In the US, some surgeons still offer the full fundoplication, which I do, because the jury is still out on whether or not the full wrap is more durable, putting stomach to stomach together. The second operation that we offer is the LINX device. So in addition to doing a hiatal hernia repair, we have this magnetic sphincter augmentation. It's basically a necklace of magnetic titanium beads that go around the esophagus, and it opens when you get a food bolus through it, and it closes back up and kind of acts like a valve. That one has a higher rate of trouble swallowing, and in fact, about 10% of patients now are asking to have the LINX removed because it causes so much trouble swallowing. So there's less and less people doing the LINX device. The TIF is a fundoplication from the inside, very similar to the fundoplication that we do from the outside surgically, really being done more investigationally right now. There's clinical trials going on to see if it does offer better control or maybe less side effects than the standard fundoplication that we do surgically. Finally, there's the Stretta. The Stretta is radiofrequency ablation, so you're strengthening that sphincter muscle by a machine that goes into your esophagus. The issue with that is that it's only 50-50 that it works. It takes 6 to 9 months to work, and oftentimes insurance doesn't cover it. So the most common operation that we do today is the hiatal hernia repair with the partial fundoplication or the toupee fundoplication. As far as the diagnostics go, so every patient has to get an endoscopy. They have to get a pH study. The pH study is a capsule that sticks to the esophagus. You wear a Holter monitor that attaches to it, and it records how much actual acid is coming up into the esophagus. gives you a score. If it's above a certain threshold, 14.72, then you've got pathologic reflux. It confirms that your symptoms are from acid reflux. And finally, the esophageal manometry. So that's a study that with a probe that goes into your esophagus. You have to be awake for it, unfortunately. It's a little uncomfortable, but it's very informational. It tells us how well your esophagus is moving. Is your contractile force good? Are the muscles moving in tandem together? Is the sphincter too loose or too tight? Depending on the findings on that study, you may or may not be a candidate for the different types of operations. And finally, as far as follow-up and post-operative, all patients go home on a protocol diet. So you're on pureed foods for 1 week, soft foods for 2 weeks, and then chopped foods for 3 weeks. So for those first 6 weeks, you gotta be very careful with how you eat. You don't want things to get stuck. Most of the feeling of things getting stuck and the bloating, which is the biggest side effect of this operation, most often improves at about 3 to 6 months. You're in and out of the hospital typically in 1 day, you're out of work for about 1 week, and there's a lot of follow-up with us. So we see our patients at 1 week after surgery, 6 weeks, 12 weeks, which is 3 months, 6 months, 9 months, 1 year, and then once a year after that. We even screen our patients after first year with endoscopies to make sure that everything looks good.